Okay, in the interest of time, I would like to welcome our last speaker, uh, Professor Yu, who is going to share his interesting case with us.
Before my talk, I want to have one comment for my previous speaker. I think that because your embolization, because the device not V-safe. If the no aortic rim, the device always V-safe. Without V-safe, no release device, please. V is Vietnam. So my talking about the transcatheter in Gedop defect. So this defect is quite very rare, and sometimes we are not clear indicate diagnostic because we think it's a VSD, but we need to check very carefully with the T to see the shunt between the left ventricle to right atrium. And the patient is a 47-year-old, is a second mitral valve mechanism replacement in 2024. And we are not sure it's because of the post-surgery defect or it's a congenital defect. And the patient have a complaint because of the softness and have a dry heart failure and some symptom from September 2024, and the patient have a systolic murmur, and the X-ray is quite big heart, and the EKG is normal, and you can see the echo, and you can see the high flow from left ventricle to right atrium, and the valve is good function, and the tricuspid severe TR. And we think we check and not enough by TE, and we move to MRI to make sure the shunt. And you can see here the shunts very clear from the left ventricle to right ventricle. And we check the angio. You can see here the very huge shunt. And we using the PDA device for closest defect. I don't remember the size, maybe 2018, and the patient quite good, but 2018, right? And the patient come back with the acute left heart failure with ejection fraction diminished, and the patient have a hemolysis, and this hemolysis quite very severe with anemia, and the patient getting very tired time, and we try to remove device. And for the TE before the remove device, you can see the device have a quite big restriction in the inferior rim, and we check again to see the MRI, and we choosing the second intervention. We need to using the bigger size of device. So the most difficult to snare is, but I share with you. We can using the bigger cyst, not too much like Mike do. I think can do the only one side bigger. For example, this one I using only 12 frame, and I can remove the device, and I put the very large PDA device from. Sorry, you cannot moving. And after the second device, everything getting better. And after 3 month follow-up, the patient very stable, normal, no hemolysis, and the patient can come back home, and all the symptoms improve. So for our take-home message is a quiet get-up defect can severe heart failure require proper intervention, and we need to use normally you can using the many device to close it like a 802 like a plugs, but I prefer the PDA device, and we can using the advanced TE and MRI to diagnostic before the procedure, and you need to choosing the good size device and close follow-up after the device implantation. Thank you for your attention.
Thank you so much.
Can I make a comment?
Eric,
Sorry,
please.
it always talk. We did quite a few Gerboda, sometimes from the
outflow tract, sometimes from the ascending aorta. I mostly close them from jugular because it's much more aligned. I see that you do from femoral, but I
Yeah.
prefer the jugular.
Yeah, I always femoral because for the VSD muscular, normally difficult to go from jugular is better. But this one quite not only one curve. I think that one curve is don't any problem with the device. Yeah.
Anyway, there are many ways to go to Rome, so
Yeah,
I
yeah.
respect. But from jugular is so easy, and
Yeah.
I mostly use septal for this. For
Yeah,
Gerbode, yeah.
you know, for the whole double disc device like HD device should be very good, but this is sometimes like a tunnel, and the tunnel
It's
is
different,
ever,
yeah, of course.
yeah,
If it's
yeah.
the tunnel, it's different.
Yeah,
yeah.
but this is very long tunnel,
Yeah.
and we can see the MRI. I cannot see very clear to see it's like a tunnel, but I don't think it's congenital. I think it's because of surgeon.
I had one Gerbode on surgery, one
Yeah.
Gerbode after MI,
Yeah,
and then I had one after transeptal puncture. They have
Yep.
accidental perforation of the
Yeah.
ascending aorta.
Yeah.
So all kind of
yeah, many
possibilities,
guys. Thank you.